Can we start, sir? Vinod, sir, are you there? Vinod, sir, are you there? Okay. So, participants, we are starting in a few minutes. Okay. So, sir will be joining. Yes, sir. Yes, sir. We can start, sir. So, we will start our second session of day 3. So, our speaker is Professor Vinod Kumar, sir. Please, sir.
Okay then. Okay then. Thank you. My presentation is visible?
Yes, sir. Visible. Yes, sir.
Okay. 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 Very good evening to all of you. I have selected my today's topic of talk that is medical imaging in tumor identification. So I will briefly discuss how medical imaging is used for identification of various tumors in the body. Now, in this case, uh, first I will briefly explain what is this, what is medical imaging, and how tumor identification, etc., is being done in this case. Basically, medical imaging plays a very important role in detecting the tumor, that is tumor detection, diagnose, that is type of the tumor, and monitoring, that is the progression. That means how the tumor is responding to the treatment, etc. It also provides to the clinicians, being a non-invasive technique, to assess tumor size, location of the tumor, and progression. That is how tumor is responding to the treatment. Early detection is also possible even at the incipient level, when the tumor just started developing, which otherwise with the help of general clinical examination, it is not visible, but imaging improves uh, the detection as well as treatment planning, and the output of the patient, outcome of the patient is much better. So that means imaging is very important in identifying the tumor which is inside the body, which is not otherwise visible. Various modalities which we use in medical imaging, X-ray. Basically, X-ray we use for the detection of bones. X-rays differentiate between hard material and soft material very precisely. So you must have seen that in case of bone fracture, when X-ray is taken, the X-rays are absorbed by the bones. So after absorption, the less amount of or intensity of X-ray after passing through the bone is very, very less. Whereas intensity of X-ray which passes through the air gap, that is the fracture area, absorption of X-ray is very less, so intensity will be very high. So on the X-ray plate, or you can say negative, the bones appear to be very bright, and air gap appears as black, because in case of air gap, intensity, output intensity after passing through the body becomes very high, and it gives a black impression on the negative or on the X-ray plate. And X-ray after absorption through the body or bones, intensity becomes less, so it is a bright image. Second modality, which is very common, is ultrasound. Ultrasound is basically to differentiate soft tissues. The echoes are generated when there is a change in media. So this modality is very good for studying the tumors and even for guiding biopsies. Then CT scan, that is computer tomography. Computer tomography is also X-ray based, but in this case, large number of images or scans are taken, and then it is combined with the help of computer to develop a 2D or 3D image. This is this is from the anatomical point of view. It takes the accurate location of the tumor. So CT generally is used to find out the exact location of the tumor as well as the size of the tumor. MRI is magnetic resonance imaging. It is generally used for brain, spinal cord, soft tissue. But in this case, the resolution is very high. Resolution is very, very high. So you can see that how the tumor is looking, what is the nature of the tumor, what is the texture of the tumor. You can clearly visualize the tumor with high resolution. So you can say CT gives the anatomical information, whereas MRI will give me the location, size, and the texture of the tumor. PET scanning is another imaging modality, which is basically to study the metabolic activities. So this metabolic activities helps us to distinguish between a malignant and a benign tumor. Malignant means cancerous tumor and non-cancerous tumor. So these are five modalities which are very commonly used. There are few more modalities which are also in practice or which are also used in medical diagnosis. So that the newer technologies like AI, Ankita is raising hand. Ankita, what is your question? Okay, okay. So generally, in case of cancer, you can say that PET scanning is also used for differentiation between malignant and benign tumor. But PET scanning is quite advanced type of modalities. Even before that, by studying the texture, I will touch in ultrasound. We will discuss in detail. In case of liver ultrasound images, we have seen that how the texture changes in case of a normal tumor, benign tumor, and in case of cancerous tumor. So there you will get an idea how the tumor structure changes with respect to cancer, liver cancer. I will discuss in my next few slides. You will get details. So AI and ML, this is very helpful in studying the tumors because in this case, the detection is quite automated and it does the segmentation also. No human intervention is required, and even it helps in classification of the tumor. And in some of the cases where tumor pattern are very, very weak or not visible in the with the human eye, with the naked eye, the AI ML technology, they are able to detect those cases also. So AI ML, they are helpful in automated detection, segmentation, classification, and in case of subtle pattern. So overall, we can say that uh, imaging is indispensable. These days, diagnosis without imaging, one cannot think of. For tumor identification, guiding biopsies, planning surgery or radiation, and evaluating treatment response. So even to study the progression of the disease is also possible in case of imaging. For the present, for this particular talk, I have divided my talk in 5 parts. Basically, we have I will be presenting the work done by my 4 5 PhD students in the area of ultrasound for the detection of liver tumors. So I will discuss with you in the introduction why liver was taken as the organ, why ultrasound has been taken as the imaging tool, imaging technique, and what are the type of tumors we have discussed, we have taken for this study. Second will be ultrasound image enhancement, how ultrasound images can be enhanced. This also will be my second portion of the talk. Feature extraction, what are various features, how we extract features, and what are the method we use for feature selection so that disease classification can be done properly. And last one will be conclusion. So why we have selected liver? Mostly the data we took from PGI Chandigarh. When I interacted with the radiology department, we had two professors where we interacted. One is who now he has retired. He is my colleague. He was my colleague. You can say professional colleague, Professor Khandelwal. He was the head of radio diagnosis department in PGI. He said that they are getting liver patient in large numbers, so they can provide us a large number of liver ultrasound images. And mostly the ultrasound is the first modality which we advise for to the patient for taking an images. So that means one, liver abnormalities are very common. Second, ultrasound is the first modality which they advise a patient to go for before the disease identification is done. And why liver? Liver is one of the most important gland of our body. It performs almost 500 500 functions. So liver performs large number of functions. It stores vitamins and carbohydrates, converts carbohydrates to lipids. It produces bile, which helps in digesting the food. It controls the amount of sugar in the bloodstream. Liver performs a large part of amino acid synthesis. Vitamin A is synthesized in the liver. Food is restructured inside the liver. Liver can repair itself unless the complete liver failure occurs. So that means liver is a very important organ in our body. So that was one criteria, and large number of liver patients were there, which were coming to PGI Chandigarh. Now, why ultrasonography? One, the doctors they advise that ultrasonography is the uh, uh, first test which they generally advise to the patient. Ultrasonography has advantage. It is a tomographic modality, means slice by slice we take the image, and with the help of computer we can generate a 2D, 3D image also. It is inexpensive. The ultrasound you can get in the market in 250, 300 rupees. It is reasonably affordable. It is non-invasive. No surgery, etc. is required. It is the probe is placed on the surface of the body, or you can say on the stomach, and you get real time image. Image start coming in real time. It is very good for imaging of blood flow or soft tissue. So liver is a soft tissue. For the imaging of liver, ultrasound is the reasonably best option. Ultrasound has been considered as the first examination to be performed with suspected liver lesions. There are two types of liver diseases. One is diffused. Diffused means it is spread over the whole surface of the liver. It is it is not localized, it is spread over the whole liver surface. Another one is focal liver disease. Focal liver is only concentrated in a smaller portion of the liver. It is localized, whereas it is throughout the liver. Before we start studying any of the medical imaging problem, we have to take into account, we have to understand what is the problem, what type of tumors are there, what is the nature of the tumor, how the doctor identify that tumor. We must try to understand that what are various types of tumors and how the doctors they try to classify those tumor with the help of naked eye. So we will be just converting that knowledge that which the doctors they do with the help of naked eye. We will convert that knowledge into a computer generated algorithm so that same output can be generated. Whatever is done visually, that should be done with the help of algorithms or computer with the help of computer. So diffuse liver, generally they have four types of cases which normally hospital are getting. One is fatty liver, fibrosis. Fibrosis is a reversible process. If fibrosis are there, some patches are there, and after some time they may be that area becomes normal. It's a reversible process. Cirrhosis is not a reversible, it is an advanced stage of fibrosis. And when it becomes cirrhosis, that means those fibers becomes almost dead. So it's a non-reversible process. So the efforts are generally made to detect the tumor at the early stage when it is in the fibrosis level. Chronic active hepatitis is another type of liver disease, which is a diffuse liver disease. Focal liver lesions are those where pathology is concentrated in a small area, so it is a localized, while the rest of the liver volume remains normal. So focal liver, again, classification, we have done two classification, diseased liver, normal liver. In case of diseased liver, whether the patch is solid lesion, whether that tumor is solid or cystic. Cystic means it is a first type situation. It is not solid. It is there is some palpation, there is some movement. It's neither a liquid, but it is a thick liquid sort of thing. So one is solid lesion, another one is cystic lesion. So this is the understanding of the type of tumor which we have studied. My PhD scholars, they have studied, you can say, they collected the data, and then they developed the algorithm for the analysis of or for the classification of tumor. Now, solid lesions are again two types. One is benign, non-cancerous, that is hemangioma, non-cancerous. Second one is malignant, cancerous. In case of malignant, we have primary HCC, that is origin is in the liver cell itself. Primary is in the liver only, and it is a hepatocellular carcinoma. It is a cancerous in nature. Second one is metastatic. So two types of uh, these tumors are there, and this is basically secondary, means origin is somewhere else. In one case where it is primary, the origin is in the liver. Another case when it is a secondary metastatic, when the origin is in other part of the body. So these two type of cancerous or malignant tumors are there. So ultrasound is highly sensitive at differentiating between a cyst and a solid lesion. So between cyst and solid lesion, it detects very nicely, very correctly. However, it is not as sensitive as CT and MRI. I told you that ultrasound is the first modality which doctors advise. And if after ultrasound they want to have more detailed information, then they go for CT or MRI. But in the first stage, ultrasound is advised. So CT or MRI at detecting focal or solid liver lesions. Ultrasound is highly operator dependent. This is another important point. It is highly operator dependent. Where he put the probe, how he moved the probe, and what is his understanding with respect to the tumors. So it is basically operator dependent, and only that picture he will click, which will be passed on to the doctor or radiologist for further analysis. When the lesion is very small, less than 1 centimeter in size, its sensitivity is not that high. Neither it is sensitivity nor specificity is high when the lesion is very small. So the presence, another important point is if diffuse liver disease is there, which is over the whole liver, then it further lowers the sensitivity in case of focal ultrasound. So that means these are the limitation of ultrasound. Now, then we started studying how the doctors they identify these tumors by with the help of naked eye. They try to study the ultrasound visually. So when ultrasound we focus on liver tissues or on the stomach, we get echoes. Echoes are reflected from the surface of the liver, depending upon the texture of the liver. Depending upon the texture of the liver, the echoes will be there. Intensity of echo depends upon the texture. So if it is a liquid type of, or you can say cyst type of tumor, the whole of ultrasound will be absorbed. That means echo intensity, echo reflection will be very, very weak signal. So when cyst is there, an echo means no reflection will be there. So the ultrasound, in the ultrasound, it will look like a black spot. If intensity of echo is less, if here the intensity of echo is 0, if the intensity of echo is less, we will say it is hypoechoic. Hypoechoic means this will be less black on the whiter side, but as compared to surrounding, it will be, you can say, more black. From surrounding, it will be more black, but otherwise, from the cyst point of view, it will be less black, more on bright side. Isoechoic means that echo from the tumor area and echo from the healthy area, healthy liver area, both reflection will be almost same. So to differentiate between this texture and this texture on the basis of echo intensity will not be convenient. And hyper means absorption is very less and whole of echo or ultrasound is reflected back. So echo intensity is high. So we will see the echo images. It may be black, it may be less black, it may be same with respect to the surrounding area, it may be more bright with respect to the surrounding area. So these are the 4 intensities which we try to see in the tumor. That is where the doctors also try to look at the tumor. So in case of ultrasound images, 3 parameters are generally taken. One is echogenicity. Echogenicity is hyperechoing, echo isoecho, or hypoecho, or anecho, means no echo. Second one is echo texture. The texture of that echo, whether it is homogeneous, whether it is intermediate, whether it is very random. Texture is very random or heterogeneous. Intermediate means between homogeneous and heterogeneous. So generally three categories are given to the texture: homogeneous, intermediate, and heterogeneous. Then another one is shape descriptor, whether the tumor is round, whether the tumor is oval, or the boundary of the tumor is irregular. So basically you can say the doctors, they try to study the shape of the tumor, they try to study the texture, they try to study the ecogenicity. So we also collected this information and we made our database with respect to these parameters for each and every tumor class, for each and every tumor class. Like if it is, I will just show you some liver images. If it is a homogeneous, this is the liver. This is the liver. This portion is the liver, you can say. This is a blood vessel. Now, this, you will say that this is not homogeneous. This is not homogeneous. There are bright spot, black spot. But in ultrasound, because of the scattering of the ultrasound, this type of texture is taken as homogeneous. So how we calculate this is homogeneous? Say if we take a patch of this, if I take this much patch, or you can say this patch, if I take this patch, and if I find out the statistics, what is the average value? What is the standard deviation? Maybe what is the kurtosis coefficient? If we find that statistics is not changing or changing very slowly, statistical parameters are not changing or changing very slowly, or they are periodic in nature. Some of the noise can be periodic type. So if the statistics, that is average and standard deviation, maybe we can add more parameters. So if statistics is changing very slowly or it is periodic in nature, we call this area is homogeneous. So say we take one by one the type of tumor. In case of cyst, this is the black portion. Cyst is that means anechoic. Nearly cyst is anechoic. This is a black area. It is anechoic. In case of cyst, the outer, this is the acoustic enhancement. Outside this boundary area, acoustic enhancement is there. This is the bright area. So one, cyst is black. The boundary of this is acoustic enhancement. That means more bright is there and nearly homogeneous. Inside the cyst is nearly homogeneous. And another wall of this particular cyst is imperceptible. This is not clearly visible. This is imperceptible wall, and it is normally oval shape. So we get an idea: oval shape, anechoic, acoustic enhancement, and nearly homogeneous. So these are the characteristics of the cyst. So simple cyst is anechoic lumen, well-defined wall, increase posterior transmission. Posterior, this is posterior transmission. Complex cyst, they have problem. There are some internal echoes. It is not completely black. Irregular thick wall. The wall is also not very thin. It is irregular and it is more of thick. Thick septation greater than 3 mm. Calcification is also there inside the liver. So we can have different characteristics for complex cyst as well as simple cyst. Mostly cyst, they are benign. 2.5% of general population is affected because of the cyst as the lesion. It is uh, it is not clinically, you can say by clinical investigation, you may not be able to find out. It is incidental. People go for a routine checkup and go for ultrasound, and then they may find that there is a cyst on the liver. It is 4 times more common in women. Size varies from 1 centimeter to 20 centimeter. So we try to get various characteristics of the cyst along with the texture which we have studied earlier. So this is our knowledge base to develop the software. So cyst, you will find this is the cyst, this area is cyst, this area is cyst, black area. Hemangioma is another type of tumor. This is hemangioma. So you will see that this is having some black white dots, whereas cyst is completely black. So doctors, by just looking at this is black, this is not black. There are white, black spots are there. So variable echogenicity. Echogenicity is not constant, it is variable. Here it is different, here it is different, everywhere it is different. Homogeneous appearance. Overall appearance is quite homogeneous. Overall appearance is homogeneous. Hemangioma has hyperechoic to normal liver. So normal liver, it is more bright. Say this is a normal liver. This is black and this is bright. So you can say from this, it is more bright. So it is hyper and it is round. So we get again 4 parameters. Its shape is round. It is hyper. Echogenicity is variable, but texture is homogeneous. Like this hepatocellular, it is a cancerous carcinoma. Hypercellular is, see, this is my liver. It is hypoechoic. Again, you will see from the liver, it is more bright. Heterogeneous, here you will find the texture is not homogeneous, it is randomly distributed. Even shape is not oval or this thing regular. The if you mark the boundary, it will be irregular. And echogenicity is variable. So this is how we get various parameters. This is a metastasis. Again, cancerous. Variable echogenicity, oval shape, metastasis, isoechoic. The inside and outside intensity is almost same. That is why the patch is not clearly visible. So these are the characteristics of various tumors we have taken. So then we make a tabular form or summarize cyst, anechoic, homogeneous, round or oval, posterior enhancement. Hepatocellular carcinoma, hypo or isoechoic, variable echogenicity, heterogeneous, oval or irregular. Hemangioma, metastasis, and normal. So we make this table. This is our learning about the tumor. Once this knowledge is available, we can develop our algorithm. So my first PhD student, we made this as experimental setup or experimental design. Ultrasound image, we created a database. We took ultrasound images from PGI Chandigarh. We selected the ROI, marking of ROI by radiologist. What we did in the image, this area was not, we first never went to identification of the tumor, automated identification of the tumor. I will, somebody has asked how we get the statistical parameter. I will discuss in my next slide. This is to get the knowledge, then how this knowledge we try to convert into mathematical form, we will discuss in further few slides. So the doctor, with the help of doctors, radiologists, we mark ROI, region of interest, that is the tumor area. So here we designed algorithm in uh, such a way that we take the raw images and we try to calculate the data set of SROIs, that is region of interest, segmented region of interest. Segmented region of interest means this is a tumor, a portion of this. Doctor has marked this. Then we decided that we will take a patch of 50 by 50 pixels. Same procedure can be used for. We selected a patch. That patch was say 50 by 50 pixels. A fixed patch of fixed size was taken as one SROI. So we collected SROIs. We collected 800 SROIs, that is segmented region of interest. We had a good number of images. I will show you the database. From those images, tumor images, 800 patches were segmented. This work we did manually. Similarly, the image, ultrasound image was enhanced, the scattering was removed, then again 800 SROIs were detected or collected from these images. So from these images, from 800 SROIs, we collected features, 208 features. I will discuss later on what are those 208 features. And SVM was used for classifier. Sport vector machine was used for classifier. That is, machine learning algorithms were used for classifier. In this case, we enhanced the image. Again, we calculated 292 features. 292 features means first order statistics, 9 features. Spatial gray level difference matrix, 80 features. Gray level run length matrix, 11 features. Gabor filter, 72 features. Texture enhanced feature, texture energy measures, 120 features. Total 292 features from each patch. 292 features from each patch were detected. This is a feature detected method, feature extraction method. Standard, those who have gone through a digital image imaging course, they must be knowing about these methods and features, how we calculate this. Once we calculate these 292 features, uh, we did feature selection on the basis of sensitivity analysis. There are many methods of feature selection. Sensitivity is one. See, if somebody is having, if one person is having flu and his temperature is, say, varying from 98 to 102, another person is having malaria, his temperature is also varying from 92 to 102. Third person is suffering from influenza, his temperature is also changing in the same range. It means temperature is not giving any information whether this temperature range is specific to a particular disease or not. So sensitivity analysis in that case will leave that feature. So we will select features which are quite unique with respect to each and every tumor. So if a particular feature, if its range is same for all the tumors, then that feature is removed. So there is a box diagram by which we do the sensitivity analysis. And out of 292, 208 features were selected. Then neural network classifier was used. This was one study. SVM classifier, this is another study. SVM plus genetic algorithm was another study. This was on the enhanced image. Second data set was the original data set without enhancement, without removing the scattering noise. So we directly use it. Uh, just a minute, please wait. Hey, 1 minute, please wait. Sorry for the interruption. Sorry. So one study was by taking the enhanced image, 292 features total, and 208 sensitive features. The analysis was done by NN classifier, SVM classifier, as well as SVM plus genetic algorithm. Another study was done with the original SROIs. 208 features were selected similar to this, and SVM classifier was used. Then we used the enhanced image as well as original image. From both the images, we tried to find out which features where the distance measure. Distance measure means we have the same number of features. If a particular feature in case of enhanced image, if in enhanced image, if a feature is less than from the original feature, so those features were selected. Features which were less than the in enhanced image as compared to original image was selected. So like that, 99 features were selected. Similarly, features which were more than the more values than the enhanced segment from the original segment, again features were selected. So 109 features were more, 1099 features were less. So we have not taken all the features of enhanced image, neither all the images of all the features of the original image. So less and more, both features were selected, and we use SVM classifier. And another, by combining these, we use SVM plus GA classifier. So we did 6 study. So this work I am presenting, which is not of one PhD scholar, it is a work of 2, 3 PhD scholar. I am just giving you a general idea that how research problem can be planned. Now, I will discuss the result also. Enhancement method, there are various enhancement methods, and we have used speckle reduction techniques. Lee filter is there, Cohen filter is there, Frost filter is there, non-local mean filter is there, wavelet based, and isotropic. We have used isotropic diffusion filters. Deep learning is also used. Now, there are certain technique in case of digital speckle filters. Those who have gone through DIP course, digital image processing, they must have studied adaptive local statistical filter, non-local means filter. There are many type of such filter. So you have to uh, study these filters. Then depending upon your research problem, you have to select a particular filter. So this is again a research problem. Then in case of deep learning also, there are various models which are available. CNN is there, GAN is there. Like this, we have transformer for image denoising. Hybrid approaches are also there. So there are some databases available. So implementation, how we can do this, this is also, you can say, you can plan, you have to plan. So basically, how speckle reduction can be done, again, you have to use a particular type which is best suited to your application. At that time, this work was mostly around 2016, 2014. So anisotropic diffusion was very common or more appropriate. because that time deep learning algorithms were not in that common in those days. Now my students are using these deep learning algorithms also. So if I try to analyze, we have my research scholar, they have used all the filters. They have tried to study it, which one gives the better result. In case of Lee filter, noise reduction is moderate. Edge preserve. Our aim is, in case of a tumor, noise should be reduced and the boundary or edge should be preserved. So these are the two important things. Noise should be removed as possible as edge should be preserved, so that boundary, so that size should not be disturbed, and computational time should be low. So for frost filter, Quinn filter, all these filter study was done, and we found that wavelet is one which is quite good. Local mean filter is also reasonably good, and isotropic is also reasonably good. But we found that the results which we got by an isotropic diffusion filter were most acceptable to the medical practitioner. Actually, after applying these filters, we generated various images. Those images we gave to the medical professionals in PGI, the PGI PG students, and all the images were coded. So we asked them which image you feel is better looking. So they randomly gave the rating. On the basis of their rating, an isotropic diffusion filter got the highest rating. So we consider these filters to be the best filter for removing the noise. So we propose a speckle reduction isotropic diffusion filter, and the filters were modified, and template we tried 5 by 5, 7 by 7, 9 by 9. And again, with different size of the template, the filtered image we created, and again we gave to the medical students to get their opinion, so that we can identify which template is the best one. So these are the template which we used for filter image enhancement. So see, this is HCC image. This HCC image, this is after SRAD operation. This image after SRAD operation, we want to reduce this speckle noise. We want to enhance the boundary. So this is not giving good result. This is by 5 by 5 template. This is by 9 by template. This is a modified method. This modified method, if you compare this one and this one, or this one and this one, you will find this gives the better result visibly. So similarly, SRAD, MSRAD, in this particular case, this is giving better result as compared to this. Similarly, in this particular case, these are various, you can say, images. Actually, the type of the image is not visible. Yeah. Original image, then SRAD, MSRAD. So this MSRAD gives me better results. See, this one and this one. So similarly, this is another image. This is another image. So we applied these filters to enhance the images. So we took the opinion of the doctor. That is one thing. Second one, then there are performance measures in the image processing. So we have correlation coefficient, beta matrix, universal quality index, figure of merit. These four index also we calculated. When we selected that this method gave the best result, we we measured these parameters. In case of simple speckle reduction filter, and in case of our modified speckle reduction filter, we found that performance has improved 0.63 to 0.99. It should be nearly 1, 0.99, 0.999, slightly better. 0.7, 0.99, much better. 0.999, it is almost near 1. So this is slightly better, but almost same. So this was one study that how specker reduction was done, which is the best method uh, uh, to use for this specker reduction, and which one is acceptable to medical fraternity also, medical students, that is PG students, those who are already they have done basic education in radiology. Now, another one is how the ROI are marked. First, the doctors, they mark this area as the tumor area. So they just mark like this. They mark with the help of a pen, red circle, say this is the tumor area. So in this tumor area, we selected these patches of fixed size. All the patches we took fixed size. So patches were taken in such a way that it is the whole patch is from the tumor. Whole patch is from the tumor, inside the tumor. So from this patch, you can say 6 patches were taken. From one tumor, 6 patches were taken. All these 6 patches, they were from the same tumor. So ROI marked by the experienced radiologist, and SROIs were selected by the research scholars. So now comes to the feature extraction, how features are extracted. That is, once we selected that this is my patch, for this particular patch, if it is 50 by 50, that means we have 50 into 50, 2500 pixels. Using those 2500 pixels, we can calculate mean value, standard deviation, energy, entropy, contrast, homogeneity, correlation, variance. So somebody asked how statistical features are calculated. So if this is the patch, you can add all the pixel intensities, you will get average value. Similarly, you can calculate standard deviation and other parameters. These are the standard formulas which we can, yeah, I will give you some formula, say for feature extraction, we have used here. One is the statistical method and another one is signal processing. We have not used model or structure based method. In case of statistical, we have used first order statistics, second order statistics, and higher order statistics. In first order statistics, histogram was used, and in second order statistics, gray level difference matrix was used. In higher order statistics, we use gray level run length matrix, ACM, etc. And in signal processing, we use spatial domain, that is in similar to time domain, then frequency domain, and spatio frequency, that is wavelet. So in spatial domain, time domain, or space domain, you can say, we calculate texture energy measures. In this case, we calculate the frequency measures and short time Fourier transform, number of frequencies, and power spectra of each frequency. So here we calculate the wavelet transform and genetic wavelet transform. So first order statistics, FOS, spatial gray level difference dependency matrix or difference matrix or co-occurrence matrix, different places you will find different names are given. This is a co-occurrence matrix, gray level run length matrix, loss 2D filter, that is texture energy measures, Gabor filter, GWVT. So 9 first order statistics filter features, 80 second order, 11 gray level run length matrix, higher statistical features, 72 texture energy measures, 120 Gabor filter. Overall, 292 features were selected. Out of 292 features, 208 features are selected as sensitive features. Now we have again come back to the uh, research or actual implementation level. We have SROIs. For each SORIs, we have selected 292 features. From 292 features, we selected 208 features. For each SROIs, we had 208 features. And we have taken 5 liver images class, 5 classes of liver images we are trying to classify. So these are simple methods to calculate minimum, maximum, mean values. These are standard formulas. Second order statistics, that is gray level histogram. That is second order, we take pair of pixels. In first order, we take single pixel. Second order, we take pair of pixels, you can say. Co-occurrence matrix, etc. So in gray level co-occurrence matrix, we calculate angular, second moment, contrast, correlation. These are standard features. So 14 features we calculated for each parameter. Run length matrix, run length features also we calculate similarly. So texture energy measures, it is basically a filter for level detector. That means averaging. So for averaging, the coefficients are 1 to 1. This is in one-dimensional data. For edge detection, that is first difference, that is edge detection, the coefficients are generally -101. For Laplacian second difference, that is second order differentiation, second difference, this is spot detection, -1 to -1. These are the standard, you can say, coefficients of the filter. Those who have read again digital image processing, they will clearly understand. This is a signal processing filter coefficients when we apply on a data for averaging, means low pass filter. This is first difference. This is, you can say, high pass filter. This is second difference, that is Laplacian filter. And in case of two-dimensional, from this we calculate two-dimensional features. That is, first I will give you texture energy measure for 3 point. This is for 5 point. That is L5, L3 convoluted with L3. These are the 5 point. This is L3 with E3. That means average and you can say edge detection. Similarly, we have S5, W5, R5, L7, 7-point filter, 7-point filter, 9-point filter, 9-point filter. So all these filters we used for calculating the features. I told you texture energy features were large in number. Texture energy features were 2D filters, 72 features were there. Texture energy measures were 72. Gabor filters were 120. Coefficients were there. So like this, and for two-dimensional, we convolute this with this, this with this, this with this, like this. So we get L5, E5, E5, S5. So we get a two-dimensional filter and filter mask. And with this mask, we operate on the SROI, that is on the image. So Gabor filter, Gabor coefficient also we calculate like this. Now, after doing this, the features, we did analysis using neural network. I told you that 6 studies were done. 6 studies were done. That is when we planned the research proposal, result of study 1, 2, 3, 4, 5, 6. 6 studies we did, and the result of these 6 studies. So these were the lesson learned, which method is the best one, and so on. Now, in case of neural network, this 6 cases were there. 5 identification was correct. 1 was wrong. 1 was detected as HCC, whereas it was cyst. In case of HCC, 155 detected correctly, 2 detected as cyst, 6 hemangioma, 3, yes, DIP is necessarily is very important. Signal processing is also very important if you want to study the you can say, classification of the images. See, when you use a machine learning algorithm, features are required. If you go for deep learning, etc., direct images, even then some idea about the images is very important. Otherwise, even in machine learning, even in deep learning, how the network will be, you can say, learned, whether it is on the basis of tumor or it may be on the basis of some other pattern in the image. It is a blind box. So that also I will try to touch sometime if time permits. So that way, uh, being a black box, how the classification is being done by the deep learning algorithm is not known to us. So that way there is a big question. So this is another approach which is quite useful, where you know that on which basis a decision is being taken. In case of SCC, accuracy is 92.8, hemogyoma 76.7, metastasis 72, normal 92%. So overall this thing. Actually, in medical imaging, this 86 has nothing, no meaning. We cannot even tolerate few cases. We want our algorithm should be very, very accurate. So this is the first study where we get a feeling which method, which methodology, which type of features are best suited for classification purpose. In case of SVM, you find that cyst we have 15 and one case. SCC 170 to 170 corrected, 2311. These are the incorrect classification. Similarly, in this case, but overall accuracy is slightly better. Overall accuracy as compared to neural network with the same feature set is slightly better. We then thought SVM and neural network they are not giving very correct. There are certain problems. Like in case of cyst, the confusion is between cyst and HCC. In case of HCC, the confusion is between SCC and hemangioma, SCC and cyst, HCC and metastasis, SCC and normal also. Similarly, in case of hemangioma, SCC and metastasis. In this case also, in this. So we tried then another exercise to see how much, if binary classification we do, how much differentiation is there between cyst and HCC. See, in case of binary classification, what we get in case of neural network output, the probability of cyst may be 0.8, probability of SCC may be 0.2. So that means that there is clear-cut difference between two probabilities. One is 0.8, another one is 0.2. So we just see that if the difference is clear, then it means this is doing the better job. Cluster separation with original data set 0.83. Cluster separation with the enhanced data set 1.67. So cluster separation in enhanced data set is better. Percentage difference, so there is an increase from 0.83 to 1.67. In cyst and hemangioma, again it is increased. Cyst and metastasis, cyst and HCC. In SCC and hemangioma, the cluster separation is poor, 0.32 and 0.4. In this case also, cluster separation is 0.3, which is not high, and between enhanced and original, there is no difference. But in case of HCC and metastasis, the cluster separation is very less, very less. Similarly, in this case, but in case of this, enhanced image gives better cluster separation. So this study gives us where we should increase more number of features to increase this cluster separation. We must have cluster separation with respect to between any two classification. If the cluster separation is high, the overall classification will be better. How it should be done? So we again try to study, say if we take only first order statistics, 9 features, after reduction, 5 features. So if we use only these features, classification accuracy is 76 based on SVM. If we use facial gray level difference matrix, this. So with each and every set of different features, we studied that what is the level of classification. So this gave us clearly a picture that all these features, they are giving us classification accuracy, which is quite high. Combining these, the accuracy, overall accuracy can be improved. We use other methods also where the classification accuracy was very poor. So we have not considered in this. So all those exercise which we did, apart from this, I am not discussing in this case, but that also was a lesson learned for us. So we get another knowledge that these methods, these feature extraction methods are reasonable, and even individually they are contributing in classification. So then what is the next? So what we thought that uh, we should try to consider, see some of the images of the uh, tumor, from the segment of the tumor in some ultrasound, different ultrasound machines were there. That ultrasound from the image from the tumor area as well as from outside the tumor area, depending upon the intensity of ultrasound when it was taken, depending upon the machine, there was relative difference in intensity. Say, if outside the tumor intensity is high, and then inside the tumor will also relatively intensity will be high. If the outside the tumor intensity is low in the ultrasound taken by the ultrasound machine, inside will also be low. So that means there should be a relation between intensity of the ultrasound patch outside the tumor and inside the tumor. That relative intensity level should also be taken into account. Further, feature space dimensionally reduction before the designing of the classifier is to be taken again with a question mark. Can we use these feature extraction method in any? Yes, these are the standard feature extraction method. They, the students, they used to discuss with me, then we used to decide and we plan for the strategy. These are the standard feature extraction method. That is why knowledge of digital image processing is very, very important. Without that knowledge, you will not get an idea how the feature extraction or what type of feature extraction will be important. So what we did, we took ROIs inside the tumor, that is ROIs, inside ROI. We took ROIs outside the tumor also, from the healthy liver surface. So we took additional ROIs from inside the tumor, already we have taken. Now we took some ROIs outside the tumor. That means from the surrounding area of the tumor. See, this is how we did. These are the ROIs from the inside the tumor. Inside the tumor. This ROI is from outside of the tumor, that is from healthy area. Here precaution is to be taken that all these ROI should be at equal distance. See, when probe is here, we put a probe. depending upon the distance of this ROI with respect to this ROI, the level of intensity, eco-intensity will change. So all SROIs and IROIs are to be taken at a same distance. So an arc is drawn, all ROIs should be taken along this arc so that they are from the same distance from this particular probe or from this particular lever. This is very important. So we took this ROI also and these 4 ROIs. We took these ROIs and one ROI we have taken from the surrounding. We took this ROI from the surrounding. So this arc, another arc we will make here. So we will make another arc here. So one SORI is from here, one SORI from this arc, another SORI from this arc, another arc that I have not shown. So another arc will be this. So one SROI for these ROIs will be this one. Another SROI will be for this IROI will be this SROI. So like this, we selected SROIs and ROIs. So this is a normal liver. A is a normal liver. B is cyst, dark patch is there. T is hemangioma. Here you will find we get less number of patches. And D is HCC. Again, it is a scattered. Metastasis, again it is scattered. So in normal, you will find that more number of patches you can get with one SRIs. Now we have modified our test data. So for another PhD student, 57 images were taken. Out of 57, 47 was lesion with tumor and NI 10 were normal. Necrotic area is basically, somebody has asked a question where some blood vessel is there. Some blood vessel, etc. is there. So that area we do not consider while taking the patches. So 57 images, 47 lesion images, 10 normal images. So we took 49 patches from the tumor and 59 SROIs, 200 IROIs from 49 lesions. 49 tumor areas out of 49, somewhere we took 4, from some patches we took 5. So 200 ROIs and 59 SROIs. So this one, our image for the training set. Similarly, this is 57 images. Here we took 51 images. Tumor 47, 41, 40, normal 10, normal 11. Lesions were 41, here lesions were 49. SROI is 52, SIROI 180. Here you will find that initially we were very, you can say, poor in data. Data was a real problem, and all PhD students, they have a time bar also. They have to finish their work in 3, 4, 5 years, and collection of data was taking lot of time. And once you start studying, your algorithm start analyzing, then you freeze the data, whatever data is there. So our data was not equally distributed. You will find data, depending upon the number of cases, the data was not equally distributed, whereas in machine learning or deep learning, we feel the data should be equally distributed, otherwise biasing problem will be there. So normal image is 10. We have said normal image is 10, SRI is 10, and IROI is 30. Cyst, only 4 images, lesion 4, and out of 4, 3 typical, lesions were typical, and another one was atypical. We also classified that when the misclassification was there, we after having discussion with the radiologist, they said that this particular tumor is a typical tumor. All tumors are like this, but this particular tumor is atypical. This is slightly different. So we said, okay, we will identify along with, we will take the uh, decision from the doctors which are typical and which are atypical. So we divided in the same image, we just marked these are 6 typical, these are atypical, so that this study we can do later on. So hemangioma, HCC, metastasis. So we prepared this data set for training, this data set for testing. You will find that a lot of time students they spent on this type of data after having interaction with the radiologist, number of sittings, number of time they visited. The students were working in IIT Roorkee. Data we collected from PGI Chandigarh. So they used to go to PGI Chandigarh. Then depending upon the availability of the doctors, radiologists, and PG students, they used to sit hours together with them. So after all this, this data set was prepared. It was also not equally distributed. It is a biased data set, but that was the limitation with us. So what we did for this study, again, we did statistical features, first order statistic, second order, higher order, spectral, that is frequency domain, spatial filter, loss filter. So we calculate 104 features. Now we modified our feature matrix. First order statistic 6. Again, we did the uh, sensitivity analysis after having previous knowledge, which are the feature which are not contributing much. So now our total features were 104 absolute texture features, and 104 we took ratio feature. Ratio feature means we calculate the feature, first order statistical feature, from IROI and same SROI, and we took the ratio of that, so that we can see that these two features, they have this ratio, and this ratio we used for our classification also. So now another proposed study, we had a marking of IRIs and SROIs by radiologist. We took 111 SROIs and 380 IROIs. By this time, our number of ultrasound images were increased. That is why from the previous data set and this time data set, we had more number of images, more number of IROIs. So statistical feature 6, gray level, co-occurrence matrix 13. Like this, total features we could get 104, and 104 ratio features. So total 208 feature, 104 plus 104, 280. Then feature dimensionally reduction by principal component analysis, we tried to reduce the features, those features which are not that much contributing, we rejected by using principal component analysis tool. So we could get a reduced texture feature vector. So we use SVM. This is one PhD scholar work. Normal, cyst, hemangioma, SCC, same 5 diseases. So 5 studies were done. One TF1, one was only with 104 absolute texture feature. Absolute texture feature means this, not ratio feature. So we tried to get the classification with SVM using only absolute texture feature. Then second study by using ratio texture feature. Third study by using both. So first study was using 104 absolute texture feature. Second study by using 104 texture ratio features. And third, combined texture features, that is 208 features. The results we got, the SVM classification result. Normal 30 for training and test 40, total 70. So total 200 plus 180, 380. Here we tried to use slightly balanced data, not exactly, but slightly less. Earlier you have seen that we were having only 4 cyst cases. Now the difference is there, but not that much. So here classification, in case of normal, you will find 32 normal, 5 HCC, and 3. That means out of 40, 32 correct, 5 and 3, they are misclassified. So 32 out of 40, 80% accuracy. So we got this percentage of accuracy. Classification accuracy overall 66. Very poor, very less. Result 119 out of 180. This was a study. You can say this is a research work. Then you go on improving, selecting different parameters so that results can be better. With the feature vector 2, the results were slightly better with the ratio features 70. So you will find same data set, and this is almost same. Only one case was different, 32 normal in this case. Here SCC 5, metastasis 3. Here in the next study, it was 4. So you will find slightly different results, but not much. The accuracy slightly improved, 70 overall, or whereas in this case, it was 66.11. 70 and 6.66 is almost same, because in this case, the data set, when it is not equally distributed, data set is not very large. So this much difference can be there between two methods. Both methods can be seen as similar result. So in case of 3, it is better, 86. When we use both features, that is original without ratio and ratio features. So here you will find in normal, the difference is not much, but overall accuracy is better. So we could get an idea that if we have ratio features along with the normal features, then our result will be better. So then what we did? Then we try to reduce the dimensions, means by using principal component, so that only selective feature should be used. If the feature is not contributing much, then it may, one, will be biasing the classification. Second, the computational time will increase. So it will be unnecessarily a load on the algorithm execution, as well as it may even do the biasing in the result. So we use PCA as the principal component analysis for reduction of dimensionality. So next, texture feature vector 4 by using PCA, and in PCA we use 5 principal component from each category. Our result became 90.17. So we could improve our result SVM with texture feature, same data set. So results are 87.2. And further, when we improved this by using SVM, we could go up to 90.3% or so, 90.17%. So again, we never left at this particular point. We again tried to do the analysis of misclassification analysis. At each point, we tried to understand where the classification is not correct. In case of normal, 40 cases, 34 correctly classified, 6 misclassified. So 1, 3, and 2. So that means 87.2, all normal. We then discussed with the radiologist. All normal cases are considered as typical as there is no atypical appearance of normal liver lesion. So radiologist said all the 40 are typical. There is no atypical. So that means this misclassification is not because of atypical cases. So means we have to improve our feature vector only. In case of cyst, 25 cases, 13 cases were normal, typical, and here 12 cases were atypical. But 24 cases were classified correctly, 1 misclassified. And misclassified 1 out of 12 atypical cyst cases is misclassified. So here 1 atypical case is misclassified. Even rest of the atypical cases are classified better. So this gives another positive output that here only 1 atypical case was misclassified. So that means this case has to be discussed with the radiologist separately. Is it very seriously atypical? Even they also find it difficult to classify, or something else, or that particular patch is not properly taken, or that image itself is not properly taken. So we discussed that also. So we prepared our notes from that point of view also. Hemangioma, 6 typical and 24 atypical cases. 24 atypical cases. 27 correctly classified, 3 misclassified. 1 typical misclassified, 2 atypical misclassified. So here 1 typical and 2 atypical misclassified. So we again discuss whether these atypical and typical are clearly visible with the naked eye or there is some issue. So like this HCC cases, we saw that 35 correctly classified, 5 misclassified, 1 out of 9. Here, in case of HCC, the typical and atypical is not that important because their nature is almost same, but size is important, large and small. So we find 1 out of 9 small is misclassified, but 4 out of 31 large also misclassified. So even small and large in both the cases, misclassification is similar. This is data is 4 times more, so misclassification is also 4 times. So this is 10% roughly misclassified. Here also it is 8 or 10%. So we get this information. Similarly, we get in case of metastasis, we get 1 out of 5 typical, 7 out of 40 are typical. Metastasis is definitely difficult, even with the naked eye. Doctors also said here we also make the mistakes. So this was overall learning from this particular study, that how this can be improved. Then again, we improved the features, and from features, the results we got much better. So those results I have not presented because that was their work, and then it was published, and good publication was there in from all these 5-6 PhD theses. So recently we started working on transfer learning model, that is using transfer learning uses a pre-trained model, ResNet, DenseNet, EfficientNet, etc. CNN was taken as pre-trained model, and final layers we took from our liver tumor images. So this is basically we are calculating the features with the help of deep learning by using transfer learning model. So here input is liver CT images, pre-processing intensity. Here we do intensity normalization because our experience was that for different images, the ROIs, IROIs and SORIs ratio should be taken, or overall image, different images, normalization of the intensity. That means intensity of the image should be average value, maximum, minimum value should be brought in a particular range. ROI extraction, resizing. The 50-50 we took, the size of ROI was also improved. Purpose, make data consistent and reduce noise. So that if there is any noise, etc., can be reduced, and all data images are almost consistent. Pre-processed liver tumor images ready for. Now, these pre-processor images, liver tumor images, we gave to CNN. The results I will not present here. So, pre-trained CNN network, the lower limit layers, earlier layers were frozen, where the general features were extracted, like edges and textures, and upper layers, the last few layers, were adopted to liver images. So output in that case becomes high level features of liver tumor. So network was last few layers were trained on the liver images, and earlier pre-trained CNN model was taken. So then global average pooling to reduce the feature map, fully connected layer for classification, and sigmoided layer to predict the tumor classes. So we, at first level, we did 3: SCC, metastasis, and cyst. So that here the data is also equally distributed. No biasing is there. So this was the model which some of my students, they are working on this. So basically liver CT images, then pre-processing, then pre-trained CNN, and global averaging pooling is there, fully connected network is there, then classification. So this is so I have discussed with you first experimental setup where 6 studies were done. Then second setup where SVM was used with the IROIs only, IRI by SROIs ratio only, then combined features. So, and with the principal component analysis, reduce features. So 4 studies were done: TFV1, TFV1, TFV2, TFV3, combined TFV4 with principal component analysis. And this was what I just wanted to share with all of you. If you have any question, you are most welcome. I'm here to give your queries, etc., if any. But I just wanted to discuss with you how a PhD problem in this particular area can be dealt with.
Yes, students, we are open for the question. If you have any question, please do type. We would take it at one by one.
I will close this just a minute. Yes, please.
Yes.
Your questions, please. Hello.
Yes.
Dr.
Question.
Pravesh. Dr. Pravesh, wonderful presentation,
Wonderful
sir.
presentation. Can we go with the deep learning model without knowing too much about the digital image processing?
Deep learning models can be used, but again, you will find that if you have already gone through deep learning model, how the classification is being done, where model is being trained, is a big question mark. It's a black box. We should try to understand the image. Blindly, we should not go. Image processing course you may not go through in detail, but some idea should be there. That is my feeling.
Okay. And the next, what is necrotic area is what? Sir,
That I have told, there is a blood stream, etc. That area we avoid because that is not tumor area. Blood vessels are there. When ultrasound images are taken, the blood vessels, etc. are there. Those blood vessels area we ignore. We do not take any patches from them. Otherwise, those area and cyst will look like same.
and Monica has asked, can we use these, can we use these features extraction methods in
Oh,
any
yes,
type?
yes, yes, yes. Monica has asked, can we use these feature extraction method in any type? Yes, actually, these are the digital image processing tools. We have to find out which feature method is best for your application. So that is why digital image processing background is important. Otherwise, you will not get an idea what are various tools which are available and what are their characteristics. So then you can intelligently decide which feature method will be best suited.
And next, Rachna ma'am asked us some procedure can be used for identification of tuberculosis. Same procedure.
Same
See,
procedure, same procedure.
yes.
So same you will use transfer learning model, you will use CNN, and last few stages of CNN, you will pre-train network you will take, then you will refine your output by using your own data like that.
And
Data
Sasank,
augmentation. Data augmentation is very important since earlier we were not using a deep learning model. Now we are using deep learning model. So for avoiding biasing, so we are doing data augmentation in this case so that equal number of cases are there for each and every tumor. Record probably this today's lecture must have been recorded. Dr. Amit must
Yes,
be
yes,
doing.
yes. We will. We have already shared the previous student record to our Canvas platform. So please join the Canvas platform. You will get all the details over there, including material.
Sir, is there a source for obtaining this data if we want to do related work? See, this data we have collected and you can say ownership of PGI Chandigarh, ownership of IIT Roorkee. There is a MOU also. I can give you few cases, but overall data is under MOU between two institutes.
which quantum layers we use with ANN model? Monica ma'am
Which
asked.
quantum layers. See, in case of ANN model, I can give you the detail. I can give you the paper which has been published, where you will find that what is the type of ANN model we have used, how many layers were there, and how many input parameters were there. All the details are there in that. I can give the reference, not an issue. See, actually, all these work was done by uh, 3 4 students or 5 students, and everybody has 2 3 SCI paper in good journals. So that means on this study, around 15 16 research publications are there in good journals overall. So they can be referred. If you just Google also, you will get these papers. IIT Roorkee, you can give the reference institute. So you will get Vinod Kumar IIT Roorkee, you will get a list of publication. Or you can write to me, I can send the paper.
Is there any further question? Okay. It seems that there is no further question. Thank you, sir. Thank you, Vinod sir,
Okay,
for
thank you. Thank you. I finished
joining
only.
with us and providing your valuable time.
Oh,
to
sure.
Our online FDP. So you have
Yes,
been
I will
with us
join.
for
I will
last 3
join.
days, and you have really gave insight about the your some of the application in today. In the previous lecture also you talk about the ECG and the heart rate variability. So that really helps the students to gain some knowledge for if they want to do some sort of research in this area, then definitely they got some idea
Nice.
out of it.
Sure.
Thank you, sir, for joining. Thank you all. Thank you, sir.
Thank you.
Thank you, sir. Dear students, you need to join the Canvas. If you have not joined, please do join. Otherwise, you will not be able to get any material. And important thing is you should also give the quiz. So for that, the Canvas login is required. If you do not give quiz and you do not have a attendance, minimum attendance, then I can't help you to fetch the certificate. Okay, so this is the norm that we need to follow. Okay, so request all of you to join the Canvas and as well as attend all the quizzes as well as session. Thank you all of you for day 3. So we are wrapping up our day 3. See you tomorrow at again 5 o'clock. Thank you all of you. Stop. We will announce the quiz.
So far, quiz has not been uploaded. When quiz is uploaded, we will announce.
Got the Canvas link during your confirmation mail. Please try to read your confirmation mail again. You would be able to get the Canvas link.
Ask them to post in the WhatsApp participant WhatsApp group. Then we can